Hi everyone, it's Dr. Oliver. This is the Antibiotic Review, episode number 3. In this episode, we're going to talk about upper respiratory tract infections. I want you guys to think back to last semester and what an upper respiratory tract infection is defined as. So symptoms that we can see are kind of those of what we call the common cold. So cough, sneezing, congestion. Sometimes people can be a little lethargic. They're tired. They're sleepy. A variety of illnesses comprise the upper respiratory infection. Most are typically viral, and we talked about this, I think, pretty heavily last semester as well. A lot of these do not need antibiotics, and so it's important for us to differentiate between, is it a viral infection or is it bacterial? And then, unless there's compelling reasons, you really should not order an antibiotic for these upper respiratory tract infections. Okay, so acute pharyngitis. It's one of the 4 most common episodic clinic visits. I'll tell you, whenever I work the urgent care, I see so many cases of acute pharyngitis. This is one of the main things that people will come in for. It can be viral or bacterial, although the majority of them do end up being viral. If they are bacterial, the group A beta hemolytic strep is the most common, and it does require antibiotic therapy. And I will tell you, these people have usually had these symptoms for longer than 6-7 days. These are not the people that say, oh, I had a sore throat that started last night, and then they come in the next day to the urgent care requesting an antibiotic. That typically is viral. It's very unlikely that it would be bacterial, so keep that in mind. Only about 5-10% of adult cases of pharyngitis are caused by the group A beta hemolytic strep, and then streptococcal pharyngitis is most commonly seen in children ages 5 to 15, and it's rare in preschool children, so keep that in mind too when you are taking care of children. So other causes of sore throat include allergies, viruses, as we talked about, cigarette smoking or secondhand smoke, especially if, say, someone is not a cigarette user and around the holidays they're going home and they're seeing family members that do smoke, and then they might come to you after a holiday complaining of a sore throat. That might be something that is a factor and something for you to ask about. Environmental causes, dry air. I always suggest people use a humidifier around this time of year because the dry air really can cause a little bit of a pharyngitis type symptomology. And then gastric reflux. So really the main lab test that you need to be aware of is the rapid strep. This is the one that's most commonly used when somebody comes in and complaining of a sore throat. For some places, speaking specifically from Ohio Health, we have to document that there are 2 or more criteria that are leading to us using this rapid strep. So history of fever, and usually that's greater than 101.5, lack of cough, tonsillar exudate, and then tender anterior cervical lymph nodes. So those, I have to document those when I am ordering a rapid strep. So that's something just to keep in mind, because depending on where you work, they may require this. Although I would say even if they don't require it, I would document this because it just covers you later on in case anything would happen. Patients with none or only one of these symptoms really should not be tested or treated for the bacteria, and then testing is generally not done on adults or children under the age of 3. And then in children or adolescents with negative rapid strep, it should be backed up with a throat culture. And so that's another lab test that you can order. I usually, when they come in to the urgent care, we usually end up ordering both of them. And that goes per location as well too. So that's something important to ask when you are out on your own and you are training with someone. Let's talk about treatment now. No antibiotics when it's viral. And this really, the main thing that you're going to be doing for patients here is education, because a lot of them will be, they'll be confused on why you aren't going to give them an antibiotic. And so that's a great opportunity for us to sit down and have a talk with them. Recommended treatment with antibiotics is 10 days if it's bacterial. The penicillin or amoxicillin is recommended for initial treatment of the bacteria. And then if a patient is allergic to a penicillin, you can use a first-generation cephalosporin, such as Keflex. I like that one a lot. Macrolide, another popular one would be the Z-Pak that you see, or the azithromycin. And then clindamycin, although I typically try to stay away from clindamycin because it does give a patient a higher risk of developing C. diff. So I usually will stick to my amoxicillin, my Keflex, or my azithromycin. For acute pharyngitis, fluoroquinolones are not appropriate. Now let's talk about rhinosinusitis, and you'll see a lot of this as well too, especially around this time of year. Again, most cases are viral. In both adults and pediatrics, about 90 to 98% of cases are viral, and it usually resolves within 7 days. Bacterial are usually caused by atypical microorganisms. So double sickening is symptoms that last longer than 10 days. So more than likely it started out as a virus and now bacteria is present. And so that's why you're seeing these symptoms last longer than the 7 days. A lot of these patients will have nasal congestion. A cough will be worse at night due to the drainage, the postnasal drip. Facial pain, some of these people will have above or below the eyes that worsen when the patient leans forward, or when you're doing your exam, if you're pressing on their maxillary or ethmoid sinuses, they will have some tenderness. Or sometimes people will even say, oh, it's kind of relieving because you're moving that fluid around in there. Some will even have a toothache. So if the maxillary sinuses are involved, it can feel like a toothache. They can develop a sinus headache is what a lot of people will call it. Purulent drainage also, although nasal drainage alone is not a good predictor of bacterial infection. So people will come to me and they'll be like, oh, I've had these symptoms for 2 days and my snot is yellow. That does not necessarily mean bacteria, but if you have some of these other symptoms along with that, then you would more so be thinking it might be bacterial. So clear to yellow to green, all different colors there. And then high fever. So typically it's 102 or higher. So I usually encourage people, if they come in on day 2 or day 3, I usually encourage them to watch and come back, 2 days later if it's not going away, or if they're still not feeling better, then I have them come back. When people are in the hospital and they're complaining of these symptoms, it's a little bit different because they're already kind of at risk because they're in the hospital, obviously, for one reason or another. So I usually will go ahead and treat them in the hospital. I'm sorry, guys. I did not spell that right. But I do go ahead and I will order some antibiotics for them. Now I'll talk about treatment for rhinosinusitis. So regardless of what is causing, if it's infectious, allergic, or if it's irritant cause, treatment really should focus on relieving the obstruction and establishing good drainage. So we want good flow of the sinuses. So we can give them some analgesics. I usually will order people, or not order, but I will instruct them to take ibuprofen if they can tolerate that with their GI system, because that anti-inflammatory property will actually go in and help some of that inflammation that can be caused by a virus or a bacteria. Also decongestants, a lot of these are, over the counter. Antihistamines, corticosteroids, sometimes people do require, some sort of steroid. I usually like prednisone. I will either do like a 4 or 5 day burst where I will do either 10 milligrams or 20 milligrams for 4 or 5 days, or you can do a taper, so you can do like a Medrol dose pack. If somebody is really bad and their cough is just very congested and you're concerned that it may go into a pneumonia with all the postnasal drip, you can order a Medrol dose pack. So people that I would think about this for would be people that are bad asthmatics or people that have progressed COPD. I would consider ordering them a steroid. Mucolytics, some people swear by Mucinex DM. I do like Mucinex DM. I do find that a lot of people will find some relief with that. So that's something that they can do over the counter. I'm also a very big advocate for the nasal sprays. Flonase is one that is fairly cheap now since it's over the counter. And I always give patients education that they have to close one nostril as they spray twice into the other nostril, and they sniff as they spray that. So just making sure that you are explaining that to them how to use these nasal sprays properly. A lot of people will actually put the nozzle of the nasal spray all the way in their nose, and then they complain about tasting the medication in their mouth. Really, it should go just slightly past the opening of their nose, and they should spray it in that way and then sniff the rest of it up so it actually stays in their nose. So a lot of people don't do that correctly. Another one that is on the market that a lot of people like, that's an aerosol, so it actually goes deeper into the sinus cavities, is called Zetona. The thing is that one is not over the counter, so it tends to be a little bit more expensive, but it does work very, very well. So now we'll talk about sinusitis. Again, this can be viral or bacterial. However, a lot of the times you'll see more bacterial with the sinusitis, because if the sinuses are not draining appropriately, it's very easy for bacteria to settle in there and proliferate. So treatment really should be continued for 10 to 14 days. For milder infections, we can talk about using penicillin. So Augmentin is recommended as the first line. If they have a penicillin allergy, then we can talk about using doxycycline or a third generation or second or third generation cephalosporin. So again, we can use that Keflex. I usually like Augmentin. Or doxycycline is really good for patients that have any sort of kidney disease, because it is not nephrotoxic, so it will not harm their kidneys if you're using doxy. And I usually will use 100 milligrams BID for 7 days for sinusitis. If a patient cannot tolerate oral medication, you could also do a single dose of ceftriaxone in the office if you have that available. Not everybody does, but if you do, that would be an option as well. Macrolides such as azithromycin are not necessarily recommended due to high levels of resistance. And so that's something, it's very important to know if there are high levels of strep resistance in your community, because if that's the case, then you want to kind of stay away from that Z-Pak use. Even though it's very heavily used, you want to try to stay away from that. And we'll talk about the antibiograms in class as well too, and knowing your community rates for certain bacteria and certain resistance. We'll talk about that in class. For more serious infections, you can use high doses of Augmentin, and then you can also use a quinolone, such as Levaquin. That one's pretty common as well too. Usually Levaquin 500 milligrams, 5 to 7 days. So that one is okay to use as well. Okay, so now we'll talk about acute otitis media. So most common childhood infection for which antibiotics are prescribed. To have a definitive diagnosis, it requires a moderate or severe bulging of tympanic membranes or a new onset of otorrhea not due to otitis externa. And then also a mild bulging of the tympanic membrane and a recent onset of otalgia or intense erythema at the tympanic membrane. So these are good things to make sure that on your assessment you are looking for. So it's really important to diagnose acute otitis media properly. You have to do a good and thorough exam. So just keep that in mind. Watchful waiting in most cases is also sufficient, as most of these cases tend to be viral. And you also don't want to confuse tympanic effusion as well too. Sometimes kids can get those and it doesn't necessarily mean it's a bacterial infection. So studies have shown that symptoms of OM spontaneously resolved in about 80% of children at 2 to 7 days. Ibuprofen or Tylenol really are the best options for pain control in children, and these are dosed per weight. Analgesic eardrops can also be provided. I will tell you, if children can tolerate them. My kids always hated these because it just felt weird to them. So keep that in mind too. If you're really struggling in the office to get a good ear exam, parents may not be able to do these eardrops at home, so it may be better just to do the ibuprofen or the Tylenol. There's really some controversy over the use of decongestants in children, because although the fluid accumulating behind the eardrum it's often a contributing factor. What I usually like to use, and this is, again, I have not worked in peds, so my peds experience comes from the urgent care or from my own children, to be quite honest and transparent. What I suggest to parents is using Claritin or Kids Zyrtec, because it really does kind of help a lot of those symptoms of that pressure, and then also the inadequate fluid drainage. It does kind of help with that antihistamine. It really just kind of helps kids get through that hump of when the otitis media is really at its worst. So I always tell people, in conjunction with ibuprofen if they're old enough, kids Claritin or Zyrtec, and then I give them an antibiotic if that's needed. I also use the kids Claritin or the kids Zyrtec with my children. Now, one thing that I have learned, though, is I always give those doses at night because it does seem to knock my kids out. Now, not every kid may be like that, but that is something that I tell parents of patients, is that I suggest that it's a once-a-day dose for either the Claritin or the Zyrtec, but I do suggest them giving it at night so that their kids are not so drowsy during the whole day, and then they'll be up all night. So I do make sure I tell them that, just to, hopefully cause less problems for them, because I'm sure the parents are sleepy too. Now, this should hopefully be a review, because I feel like we covered acute otitis media very well last semester, but amoxicillin 80 to 90 milligrams per kilogram per day remains the first-line therapy for children who have not received amoxicillin within the last 30 days. If they do not have any sort of positive response in 72 hours, you can consider alternative agents. So Augmentin is recommended if the child has had amoxicillin within the last 30 days. And then for a penicillin allergy, second or third generation cephalosporins may also be appropriate. So now let's talk about pneumonia. So common lower respiratory tract infection that causes inflammation of the lung parenchyma. So pneumonia is the 6th leading cause of death. And the defense mechanisms of the lung usually help to prevent passage of foreign materials, but in pneumonia, this is hindered. Immunizations are extremely important to prevent pneumonia, especially in our older population. On this slide, I just wanted to include some of the common signs and symptoms of pneumonia that you guys will see, and I know you probably can think of patients as you're looking at this list, but I also wanted to differentiate the classic symptoms from what you see in those in elderly patients. So just remember that classic symptoms may not be seen in over half of our elderly patients. Now let's differentiate between community-acquired pneumonia versus healthcare-associated pneumonia. So whether it's community or healthcare, either one can be viral or bacterial. And these are some of the common bacteria that you will see. And then community-acquired pneumonia is usually Streptococcus pneumoniae. So there's about a 1% prevalence in elderly patients, however, with this. So healthcare-associated pneumonia is typically acquired in an environment such as a hospital, a person residing in a nursing home, or receiving home health care or dialysis. So usually caused by very different organisms than community-acquired, which is why we do have to treat it more aggressively. These pneumonias can be caused from MRSA, gram-negative organisms. They can also be caused from fungal infections. So it's really important to make sure when they're in the hospital that we're doing a thorough exam and also a thorough workup with diagnostics so that we can get them on the right antibiotics. So let's just briefly talk about some of the antibiotic resistance for pneumonia. Over the past decade, antimicrobial resistance has increased dramatically for both community-acquired and healthcare. I will say, probably 5-10 years ago, it was more so the healthcare that we were seeing more of an antibiotic resistance, but we're starting to see it more in the community-acquired pneumonia as well. So more than 15% of the strep pneumonia are highly resistant to penicillin and increasingly resistant to macrolides and cephalosporins. So we have to keep that in mind when we are prescribing things for our patients. And again, that goes back to knowing your community. What is there a high resistance for in our community? So most pneumococcal isolates in the U.S. remain susceptible to the respiratory fluoroquinolones, such as Levaquin or levofloxacin. Cipro has limited activity against pneumococcal infection, so we typically do not use that one. We save that one for more GU infections. Some specific populations, such as elderly patients in long-term care facilities, have shown increased levels of pneumococcal resistance. So keep that in mind when you're taking care of a nursing home patient. You may have to be a little bit more aggressive with what antibiotics you use because of the environment they're living in. So for outpatient treatment for the community-acquired, we can talk about, if we know what our community resistance is and macrolides are not high on the list, we can use azithromycin, clarithromycin, although I typically will use more azithromycin. I don't typically use clarithromycin. Doxycycline, again, is another good one, not only because it offers good coverage, but also because you can use it in your patients that have some sort of kidney disease, so it's very safe to use for them. If strep pneumonia is thought to be the causative organism, then a penicillin or a cephalosporin would be the drug of choice, provided there is no resistance in that area. If resistance is an issue, then typically we will go to Levaquin to treat this pneumonia. When we look at inpatient patients, we have to be very careful with what we prescribe because we want to make sure that we cover both typical and atypical pathogens, especially until we get a sputum culture back. And I don't know about you guys, but sometimes patients are never able to produce a sputum culture. So you just have to make sure that you are covering all your possible causative organisms when you are first prescribing them a medication. So I have some of the things here that you can prescribe. I will tell you in the hospital, usually the first line that Ohio Health likes is Levaquin. If you're doing a PO antibiotic in the hospital, so if somebody has pneumonia, but that's not necessarily the main reason they're there, you can do that Levaquin PO if they're taking PO okay. Otherwise, the first line for inpatient pneumonia is Rosefin. And you can add a macrolide like azithromycin to that, and you can also do that IV as well. So typically inpatient, your medications are going to be IV. Unless the patient is not very sick and they are taking PO, then you can give them PO medication. But typically at first when they're in the hospital during that acute phase, we will give them IV antibiotics. If they have any sort of structural lung disease, like cystic fibrosis, bronchiectasis, or if you have a person that maybe has progressed COPD or asthma, a regimen with activity against Pseudomonas should be considered. And so we would consider a third or fourth generation cephalosporin plus a fluoroquinolone like Levaquin. And then if aspiration pneumonia is suspected, typically we'll add on Flagyl or clindamycin, although I typically will use more Flagyl over the clindamycin. And then if you do have a highly resistant pneumococcal pneumonia, you can consider using Vanco or Zyvox. I typically will start with the Vanco if they don't have an allergy. And these are for people, they're going to come in, they're going to be very, very sick. I mean, it's going to be, they can pretty much have a whiteout on their chest x-ray. They're going to look visibly sick. So these are the people that I automatically then would know that I would need to have something a little bit stronger. Last but not least, we'll talk about acute bronchitis. Again, this is an infection of the tracheobronchial tree that causes reversible bronchial inflammation. So remember, inflammation is a key factor in this condition. So most patients will present with a cough. Symptoms can last anywhere from 7 days to longer than 14 days. And that does not necessarily mean that it is a bacterial infection. And that's very hard sometimes to explain to patients, because when you don't feel good for 7 to 14 days or longer, typically people want it fixed and they want to feel better. So they often want an antibiotic. Bronchitis is often thought of as a diagnosis of exclusion. And then greater than 95% of the cases of acute cough are non-bacterial. Colored sputum does not necessarily indicate a bacterial infection. And again, this is where education comes into play, because a lot of patients will say, well, I'm coughing up yellow gunk or yellow sputum, and so I know that I have bacteria. And so really we have to sit down and have a good conversation with them and educate them on the difference between a viral bronchitis and a bacterial bronchitis. Now, it's very important, especially in the outpatient realm, to differentiate bronchitis from pneumonia. So pneumonia is unlikely if all of the following are absent. So keyword absent there. So if they don't have a fever greater than 101.5, if they're not tachypnic, if they're not tachycardic, if there's no evidence of consolidation on a chest exam, then more than likely it's bronchitis. Now, if they have all of those factors, then more than likely they could have a pneumonia. And at that point, it would be important to consider doing a chest x-ray if you haven't already. And then also if their symptoms are continuing on, lasting longer than 3 weeks, at that point it would be a good time to consider doing a repeat chest x-ray to see if the bronchitis has progressed to a pneumonia at that point. So for viral bronchitis, there's no antibiotics. We encourage them to increase hydration. We can talk to them about expectorants. I like the Tessalon pearls to help with the coughing as well. Or sometimes people just use good old Robitussin or Dayquil, NyQuil. Those sometimes people will say that they help. Sometimes an antihistamine like a Claritin or a Zyrtec will be helpful. A decongestant, usually 3 days or less. And then a beta agonist, so if they're really starting to wheeze, say they have a history of asthma or a history of COPD, you can consider using, if they don't already have, but you can consider using an albuterol inhaler. Now, if this is a bronchitis, then you can look at using a penicillin like amoxicillin. You can use Augmentin, or if depending on the area and resistance, you can use azithromycin or a Z-Pak as well too, if at that point you've determined that it's no longer viral but it's bacterial.